Thank you very much, Marcus. And I think we would like to thank, on behalf of the panel, the EASL Governing Board and yourself for taking this initiative of launching the EASL Online Recommendations Treatment of Hepatitis C 2014 during the International Liver Congress, which I think was one of the major breakthroughs of this meeting. So as Marcus emphasized, EASL is the European Association for the Study of the Liver. We have a responsibility for guiding treatment decisions and reimbursement policies and strategies in Europe. And as you know, Europe is extremely diverse in terms of cultures, countries, languages, cuisine, but also healthcare systems and reimbursement strategies. I believe that EASL has shown over the years that it is more than just a European association. It is also the association that organizes the International Liver Congress. And we believe that our guidelines over the past years have been published and widely used, and we also have responsibility in treating and guiding treatment decisions in other areas of the world. And we know that a lot of people from Asia, South America, Africa, and North America as well are attending this meeting and will be interested and may benefit from using our recommendations to treat their patients. So it is with this in mind that we assembled a panel of outstanding people who are here on the podium with us today, and will answer your questions and discuss after my short presentation. This panel includes Dr. Alessio Agemo, who is a member of the governing board of EASL, Dr. Jeff Dusheko, Dr. Xavier Forns, Dr. Massimo Porti, and Dr. Christos Sarrazin. And I must say that we worked in a very friendly atmosphere. It was very easy to work with these people, and this is probably why this is reflected in relatively clear and straightforward recommendations. What are our recommendations? First of all, what is the goal of therapy and what are treatment indications? The goal of therapy for the EASL recommendation is to eradicate HIV infection in order to prevent hepatic cirrhosis, decompensation, cirrhosis, hepatocellular carcinoma, and death. The endpoint of therapy is undetectable HCV RNA in a sensitive assay, less than 15 IU per ml, 12 weeks, SVR12, or 24 weeks, SVR24 after the end of treatment. And you see here that we accept SVR12 as the correct endpoint of therapy. Who should be treated? All treatment-naive and experienced patients with compensated disease due to HCV should be considered for therapy. However, we may have to prioritize, especially given the high cost of therapy, and it appeared very clear for the panel that treatment should be prioritized for patients with significant fibrosis, Medivir score F3 to F4. Treatment is certainly justified in patients with moderate fibrosis, Medivir score F2. And finally, in patients with no or mild disease, Medivir score F0, F1, the indication for and timing of therapy can be individualized. And this, I think, leaves the door open to local strategies and individualization of therapy. I think a major point in the guidelines is that we do no longer consider HIV-Coinfected patients as a special group, as a different population, and we believe that the indication for HIV treatment in HCV co-infected persons are identical to those in patients with HIV monoinfection. The same treatment regimens can be used in HIV co-infected patients as in patients without HIV infection, and the virological results of therapy are identical. And finally, potential drug-drug interactions with antiretroviral drugs should be taken into account in that population, but nothing else. What are the treatment options? Well, we will have 3 new drugs approved in the European Union in September. The first one is Sofosbuvir. It is a nucleotide analog given as a single pill once a day, 400 milligrams. It is active against all genotypes, as a high barrier to resistance, has been approved in Europe in January 2014. The second drug is Cimeprevir. Cimeprevir is a protease inhibitor available as a single tablet once a day, 150 milligrams, active against genotypes 1 and 4. Low barrier to resistance, will be approved in Europe in May 2014. And the third drug is Declatasvir. This is an NS5A inhibitor available as a single tablet once a day, 60 milligrams, all genotypes, pangenotypic activity, low barrier to resistance, probably approved in late August or early September 2014. The panel had to acknowledge 2 things, and this is a context. Number 1, these new therapies are extremely expensive. Number 2, the economy, especially in the European zone, is not that good, and this has to be taken into account, and this is a reason why we're proposing options. These options are considered by the panel as valuable. Maybe some are a little bit better, a little bit worse, but at the end, locally, the government and the treaters will have to make their own decisions based on these recommendations. I think we didn't want to exclude anything, and even if we did not include the old treatments within our options, because we do not believe it is the best way to treat patients, we included the following statements, which is that in settings where none of the new options is available, the triple combination of peginterferon, ribavirin, and either telaprevir or beziprevir remains acceptable for genotype 1. And in settings where none of the new options is available, the combination of peginterferon and ribavirin remains acceptable for genotypes 2 to 6. We do not recommend this, but we appreciate that in some areas there will be nothing else available, and we have cured a lot of patients with these regimens. What about the treatment options? There are currently, with the 3 new drugs available, 6 potential treatment options. 3 remain based on the use of peginterferon, ribavirin plus 1 direct-acting antiviral, either sofosbuvir, cimeprevir, or declatasvir, and 3 interferon-free options are available, will be available very soon. They include the combination of sofosbuvir plus ribavirin, the combination of sofosbuvir plus cimeprevir with or without ribavirin, and the combination of sofosbuvir plus declatasvir with or without ribavirin, with different treatment durations. Peginterferon, ribavirin, sofosbuvir 12 weeks. Interferon, ribavirin, cimeprevir is 12 weeks of triple combo followed by response-guided therapy. Same is for interferon, ribavirin plus declatasvir. Sofosbuvir plus ribavirin is administered 12 to 24 weeks. Sofosbuvir, cimeprevir 12 weeks, and data is lacking on short treatment in some groups. So sofosbuvir plus declatasvir is 12 to 24 weeks. We decided to make our recommendations and define our options per genotype, which is the simplest way to understand things. And first of all, these are in green the options we consider valuable in patients infected with genotype 1. They include the 3 peginterferon ribavirin-based options with sofosbuvir, cimeprevir, declatasvir, and 2 interferon-free regimens are also very valuable for genotype 1 patients, sofosbuvir plus cimeprevir and sofosbuvir plus declatasvir. The sofosbuvir ribavirin combination is not considered ideal. It's approved for treatment interferon ineligible or intolerant patients. We believe that if declatasvir and cimeprevir are available, the double combination of the 2 DAAs should be preferred to sofosbuvir plus ribavirin in that group. What were these recommendations based on? What is the evidence? Well, first of all, the Neutrino trial that clearly showed that the triple combination of interferon, ribavirin, and sofosbuvir achieved an SVR rate of 89%. This is in treatment-naive patients. Data is lacking in treatment-experienced patients, but they can probably be extrapolated. Evidence for recommending cimeprevir plus interferon and ribavirin. These are the 2 Quest studies that were presented at EASL last year, with an SVR rate of 80% in the 2 studies in patients infected with genotype 1. However, there is one restriction. If you look at the split by subtype and presence at baseline of a detectable QATK substitution, you can see that patients infected with HCV subtype 1b had an 85% SVR rate with this triple combination. Patients infected with genotype 1a who had no detectable QATK mutation at baseline had a very high SVR rate. However, patients with a 1a infection and a QATK substitution had a lower response rate, and therefore in that subpopulation, this triple combination therapy is not recommended. Evidence for the triple interferon, ribavirin, declatasvir, the COMMAND-1 study. You can see here that an SVR rate of 87% can be achieved in patients infected with subtype 1b. This is therefore a good combination in that subtype. For subtype 1a, not much data, but 58% SVR rate in the subtype 1a subgroup. This combination is not recommended in patients infected with HCV genotype 1, subtype 1a. What about the interferon-free regimens? We have seen yesterday the presentation of the COSMOS trials, and you can see here that with 12 weeks of therapy in patients who are genotype 1 null responders with relatively mild disease, the SVR rates were extremely high, 96.3% here with ribavirin, 92.9% without ribavirin. We believe that this combination is a very good, efficacious combination for patients infected with genotype 1. And finally, the results with sofosbuvir plus declatasvir with or without ribavirin were also compelling, making this combination a very valuable option for treatment of genotype 1, with patients who are treatment naive, treated 24 weeks, having 100% SVR rates, 12 weeks, very high as well. These boxes indicate that the patients were lost to follow-up, but per protocol, the SVR rates were 100% as well. And most importantly here, that combination, 24 weeks in patients who failed on a prior treatment with interferon, ribavirin, and either telaprevir or boceprevir, with very high SVR rates with the all-oral interferon-free combination of sofosbuvir, daclatasvir, with or without ribavirin, and ribavirin clearly did not appear to have a major impact on the response. What about HCV genotype 2? HCV genotype 2, the standard of care treatment now will become sofosbuvir plus ribavirin. It is also possible to use triple combination of sofosbuvir, ribavirin plus PEG interferon. The reasons for that are shown here. These are the results of the FISSION trial, the FUSION trial. Very high SVR rates expected with sofosbuvir, ribavirin in treatment-naive patients, 97% without cirrhosis, 83% with cirrhosis. In treatment-experienced patients, no cirrhosis, very high SVR rate with 12 weeks, 90%, no improvement with 16 weeks. But here we see a difference. Patients who are treatment-experienced, who have cirrhosis, had an SVR rate of 60%. This increased to 78%. And this explains that our recommendation is to prolong therapy in treatment-experienced patients with cirrhosis, prolonged it up to 16 weeks, but maybe more because we do not know what happens after that, and eventually 20 weeks of therapy. As I said before, patients who would not respond to this therapy or would have cirrhosis, treatment experience, could eventually receive a triple combination of PEG interferon, ribavirin, and sofosbuvir, and this is based on a small amount of data from the Lone Star 2 study showing SVR rate in 100% of these patients, but there were only 9 without cirrhosis, and an SVR rate of 94% in patients with cirrhosis, but there were only 14 patients. HCV genotype 3, 3 potential options. The first one is the use of sofosbuvir plus ribavirin, interferon-free. The second one is a triple combination of PEG interferon, ribavirin, and sofosbuvir, which is approved in the European Union. And the third one is an interferon-free regimen, the first available for genotype 3, if we add to sofosbuvir plus ribavirin, but with 2 drugs this time. Sofosbuvir plus daclatasvir with or without ribavirin. Again, we have evidence for this treatment. Phase 3, FISSION compared to Valence, 12 weeks in red, 24 weeks in green. You see here that 24 weeks is doing much better in treatment-naive patients without cirrhosis, 93%, and 92% in patients with cirrhosis. The ideal duration of sofosbuvir ribavirin genotype 3 in treatment-naive patients should be 24 weeks and not less than that, and this is what we wrote in the recommendations. What about treatment experience? The comparison is the same. Also values 24 weeks of therapy in patients who have no cirrhosis, achieving 85% SVR rate in the Valence trial. However, the results of this combination of sofosbuvir plus ribavirin are disappointing in patients with cirrhosis who are treatment experienced, and probably this combination is not ideal for that subgroup of patients. There are data with an additional drug, PEG interferon, this time in combination with sofosbuvir and ribavirin from the Lone Star study. Few patients included in the study, but SVR rates pretty high, 83% in patients with or without cirrhosis. And based on data we have with the same combination in other genotypes, I believe we can extrapolate these data and recommend that patients with cirrhosis who are treatment experienced, difficult to treat, be treated. This is not genotype 2, it's a mistake on the slide, it's genotype 3, be treated with a combination of PEG interferon, ribavirin, and sofosbuvir. Finally, what about the combination of sofosbuvir plus daclatasvir? This is a study that was presented at the AASLD meeting by Mark Zutkowski. Treatment-naive patients affected by genotype 2 or 3, the SVR rates were 100% for sofosbuvir plus daclatasvir and 93% for sofosbuvir, daclatasvir plus ribavirin, with a patient who was lost to follow-up, and we believe that given the interval effectiveness of sofosbuvir and daclatasvir in genotype 3 patients, this combination is going to be pretty efficacious. Genotype 4, not much data for genotype 4, but based on what we know of the activity of the drugs on this genotype and what we know of other genotypes, we believe that we could extrapolate and make a recommendation which is very similar to the one we have for genotype 1. This recommendation includes the 3 interferon-containing regimens as valuable options and 2 interferon-free regimens, sofosbuvir plus imepravir and sofosbuvir plus daclatasvir, also as valuable options. Again, the neutrino trial helped us make this recommendation. You can see here that in 28 patients infected with genotype 4, the SVR rate in treatment-naive patients was 96% with interferon ribavirin plus sofosbuvir. This is a triple combination of interferon ribavirin cimeprevir, genotype 4 patients in a phase 2 trial. 89% SVR rate in treatment-naive, 86% in relapsers, partial responders 100%, and non-responders 75%. This is finally the triple combination of interferon ribavirin plus declatazvir in the COMMAND-1 trial. Small number of patients again, but compelling data. All of them achieved an SVR. We do not have data for the combination of sofosbuvir plus cimeprevir interferon-free. No data for the combination of sofosbuvir plus declatazvir interferon-free. But after discussion, we decided that given the fact that both molecules have effectiveness against genotype 4, and given what we know from the other genotypes, these two combinations are most likely very valuable for patients infected with genotype 4. Finally, HCV genotypes 5 and 6. HCV genotype 5 and 6 do not have many options. The only option right now is a combination of pegylated interferon alpha, ribavirin, and sofosbuvir. Sofosbuvir plus ribavirin should be used only in patients who are intolerant, ineligible to interferon, but it is not optimal. And this again is based on the neutrino trial with a very small number of patients included, genotype 5 and 6. It was only 7 patients, 100% SVR rate. We obviously need more data, but we believe that given the effectiveness of sofosbuvir, which is pan-genotypic, we would have very good results for this genotype. What about treatment monitoring? Well, treatment monitoring has been very complicated in the past due to response-guided therapy, interferon duration. We tried to simplify it, and these are our recommendations for an interferon-free treatment regimen of, let's say, 12 weeks. We recommend assessing the HCV RNA levels at baseline. This is a starting point. We also recommend assessing the HCV RNA level at week 2. This is not for efficacy, this is for adherence. And the only way to know and to be sure your patient is taking the drugs is to check whether the HCV RNA is going down or not. We suggest assessing the rapid virological response at week 4, although we have seen data during this meeting suggesting that this is not predictive of the final outcome. I would say that this one may eventually be removed at some point. End of treatment response, the last point on treatment, and then SVR12 or SVR24, which are both valuable endpoints for outcome of therapy. What about patients with more advanced liver disease? We just gave you here the general scenario, but some patients have advanced liver disease, and we have to be careful in these patients. Patients with compensated cirrhosis, these patients should be treated, obviously in the absence of contraindications, in order to prevent short to midterm complications. And we here make a very strong recommendation that interferon-free combination regimens should be preferred in patients with compensated cirrhosis, and also remind you that patients with cirrhosis should undergo regular surveillance for hepatocellular carcinoma, irrespective of SVR, and this is, I believe, very, very important. What about patients with an indication of liver transplantation now? They split into two subgroups. The first one is Child-Pugh patients, compensated cirrhosis with HCC. Well, several options. We recommend sofosbuvir Ribavirin until liver transplantation. Sofosbuvir plus cimeprevir or declatazvir with Ribavirin until liver transplantation is probably better than sofosbuvir plus Ribavirin. We don't have data with this double combination, but we believe it will be better in that population. And another option that came in from our discussion is that the finite 12 weeks peginterferon Ribavirin sofosbuvir is also acceptable before therapy with the goal of curing infection before getting to liver transplantation. These recommendations are obviously based on the data that were shown at the AASLD meeting, where patients were treated pre-transplant with sofosbuvir and ribavirin. You can see here that at transplant, 93% of the patients had undetectable HCV RNA in their blood, and the SVR rate, which was in fact a rate of prevention of HCV recurrence, was 64% at post-transplant week 12, indicating that if you reduce viral replication down to very low levels, you can really prevent recurrence of infection. A key determinant of this prevention was the duration of undetectable HCV RNA pre-transplant, and you can see here that except one patient who had more than 30 days undetectable and had recurrence of HCV infection, all patients who had more than 30 days here did not have recurrence of HCV infection, whereas the patients who had less than 30 days of undetectable HCV RNA had a higher risk of recurrence. And this is based on this that we believe that the lower the viral load, the greater the likelihood that the patient will have no recurrence of HCV infection. And this is why we believe that adding a second DAA would be very beneficial to these patients. So what about the patients with an indication for liver transplantation, but this time with decompensated cirrhosis, Child-Pugh B or C? We believe that Sofosbuvir plus Ribavirin could be done in experienced centers only, under close monitoring, and we also believe that for the same reasons I said before, combining Sofosbuvir with either Cimeprevir or Decompensated according to the HCV genotype with Ribavirin would probably be better. We do not have a lot of data on that, but obviously these patients may die soon, and we have to be extremely proactive in that population. Post-transplant recurrent hepatitis C, patients with post-transplant recurrence of HCV infection should be considered for therapy, absolutely, regardless of ALT, whatever. If they have infections, they should. Interferon-free treatment is recommended in that population, and no dose adjustment is required for tacrolimus or cyclosporine with any of the available combinations. Then we had a long discussion and debate on patients with decompensated cirrhosis who are not in the transplant list, and I must acknowledge that there is no data there, and we have to be very intuitive. Our recommendation that patients with decompensated cirrhosis not on a transplant waiting list should be offered an interferon-free regimen, and this should be done only within a clinical trial, an expanded access program, or within experienced centers, because the efficacy, the safety, but also the outcomes have not yet been established for this group. We do not know if curing HCV or reducing HCV replication will have any beneficial effect on the clinical events, on deaths in these patients, and this is something that needs urgently to be established. Special groups, a few special groups were discussed. I will not spend too much time on this. You can really read the guidelines. One important special group was the patients with impaired renal function. These patients, in our opinion, should receive an interferon-free, if possible, ribavirin-free regimen. Unfortunately, no safety and efficacy data is available in this population, and the need for dose adjustments for Sofosbuvir, Cimeprevir, and Decompensated is unknown. We thus have to be extremely careful. Sofosbuvir should not be administered to patients with an eGFR less than 30 or with end-stage renal disease until more data is available. Other special groups include the HIV-Coinfected population. The treatment indication is the same according to the HCV genotype. However, you know that HCV replications reduces HBV replication, and curing HCV may restore some level of HBV replication. Therefore, nucleoside or nucleotide analog anti-HBV therapy is recommended if HBV replication is detected during, before, or after HCV clearance. Interferon-free regimen should be used in non-hepatic solid organ transplant recipients as well. Active drug addicts and patients on stable maintenance substitution. These patients should not be denied therapy. I think it's a very important point. However, treatment indication should be considered on an individual basis after careful multidisciplinary evaluation. The same anti-HCV regimen should be used, and opioid substitution is not a contraindication to these therapies. We discussed hemoglobinopathies. You should receive an interferon-free, ribavirin-free regimen. There is no data yet, but data are coming. And in the meantime, these patients have very often been denied therapy. They need to be treated, and now we have the tool for that. Bleeding disorders have the same indications as in the other groups of patients. And finally, acute hepatitis C, which is supposed to be easy to cure. We don't have any data with interferon-free regimens. We believe that interferon-free regimens will be efficacious. There is no reason why they would not be, even more than in patients with chronic infection. But in the absence of data, we decided to recommend that the same schedule be used as chronic hepatitis, pending more data on eventually a shorter or lighter treatment administration. So these guidelines have been established, and we'll have a discussion starting now. For now, this is a guidelines from April 2014. We know that other drugs may be coming. We've seen a lot of data during this meeting. We are expecting Faldaprevir to be accepted, approved at some point this year, end of this year maybe. We're also expecting that Sofosbuvir plus the Decompensated fixed dose combination will be approved at some point, as well as the AbbVie triple combination of ABT450, Ombitesvir, and the Sabuvir. And this is a reason why I think Marcus explained this very well. These guidelines are for treating patients now with what we have in any place of the world, but the guidelines will obviously be updated very soon with a newly available therapy, and we expect that before the end of this year, an update of the guidelines will come, including the new options, eventually removing old options and trying to keep up to date on these indications. On this, I thank you very much for your attention.